Welcome, first-year BHMS students. Today, we are mapping the exact anatomy of the anterior abdominal wall. If you look at this 3D rendering of the human torso, you'll immediately notice a stark architectural difference. The thorax above is protected by a rigid cage of bone, while the abdominal cavity below relies almost entirely on soft tissue. This muscular wall has two primary physical mandates. First, it provides flexible yet firm support, acting as a physical cradle to contain the internal viscera against the constant pull of gravity. Second, it actively contracts to generate the high intra-abdominal pressure necessary for biological expulsive acts, such as micturition, defecation, and vomiting. The abdominal wall functions through a specific mechanical balance. It expands to accommodate internal volume changes while maintaining the tensile strength required to shield the underlying organs. Before dissecting the layers, we map the surface landmarks that guide both anatomical study and surgical orientation. Running straight down the midline is the linea alba, a central vertical tendinous seam. Flanking this midline are the curved lateral borders known as the linea semilunaris, which outline the outer edges of the vertical rectus muscles. Situated exactly along the linea alba is the umbilicus, the central reference node of the abdomen, originating as the normal scar left by the root of the umbilical cord. Here we see an animated diagram mapping the abdomen's drainage pathways. Notice how the umbilicus acts as a clinical watershed line. Venous and lymphatic flow perfectly splits here, diverging strictly superiorly above the umbilicus and inferiorly below it. Together, these surface landmarks establish a highly reliable external coordinate system, allowing us to navigate the complex hidden muscular architecture lying just beneath the skin. A scalpel cutting into the anterior abdominal wall encounters a precise sequence of 6 layers: the skin, the superficial fascia, the muscular layer, the transversalis fascia, extraperitoneal connective tissue, and finally, the parietal peritoneum. Immediately deep to the skin lies the superficial fascia. Looking at this gross dissection, particularly the right side, we observe that below the umbilicus, this envelope splits into 2 distinct layers. The outermost is Camper's fascia, presenting as a thick, heavily textured yellow layer, indicating a highly fatty composition. Beneath Camper's lies Scarpa's fascia, which is a thin, dense, and distinctly membranous sheet of connective tissue. This bifurcated envelope efficiently serves a dual purpose. The fat provides necessary thermal insulation, while the dense membranous layer establishes a strong structural foundation before we reach the core musculature. This diagram shows the layered arrangement of the flat muscles that form the lateral abdominal wall. Focusing on the outermost flat layer, the external oblique, pay specific attention to the fiber orientation. These fibers run inferomedially, angling diagonally downward and inward. A critical structural feature occurs at the lower edge of this muscle. The aponeurotic border of the external oblique physically rolls inward upon itself to form the dense band of the inguinal ligament. Deep to the external oblique is the middle layer, the internal oblique. Its fibers run superomedially, upward and inward, orienting them almost exactly perpendicular to the layer above. This technical diagram displays the innermost flat layer, the transversus abdominis. As visible over the lower ribs, its fiber orientation is strictly horizontal. By stacking these alternating perpendicular and horizontal fiber directions, the abdominal wall achieves a biomechanical plywood effect. This exact structural arrangement maximizes tensile strength across the lateral wall to resist severe internal pressure. Shifting to the anterior midline, we find the vertical musculature. The dominant feature is the large rectus abdominis, accompanied at its base by a small, inconsistent muscle called the pyramidalis. The rectus abdominis features tendinous intersections. These transverse fibrous bands physically break the long muscle belly into shorter, independent segments, greatly increasing overall contractile power. The rectus abdominis operates within the rectus sheath. This structural envelope is composed of the aponeuroses, or tendons, of the 3 lateral flat muscles we just examined. In this cross-section, the broad aponeuroses of the 3 lateral muscles extend inward, split, and wrap around the rectus abdominis. Zooming in on the midline, these wrapping layers fuse completely in the center, establishing the dense interwoven junction we identify as the linea alba. This sheath architecture integrates the lateral and vertical muscle groups into a single functional unit. This structural union allows the soft tissue to safely distribute and contain extreme intra-abdominal pressure. Moving entirely deep to the muscular layer, we encounter the first internal boundary, a continuous sheet called the fascia transversalis. The fifth anatomical layer is the extraperitoneal connective tissue. This is primarily a variable accumulation of fat separating the fascia from the innermost abdominal lining. That final, deepest layer is the parietal peritoneum. As this macro footage illustrates, the parietal peritoneum functions as a frictionless serous membrane, providing a continuously lubricated surface. This ensures that the internal organs can slide against the abdominal wall without sustaining any structural damage. Penetrating this delicate serous lining means you have completely cleared the structural boundaries of the wall, stepping directly into the sterile environment of the true abdominal cavity. Despite this multi-layered architecture, the abdominal wall contains a necessary biological compromise, an intentional gap in the muscular shield known as the inguinal canal. Located precisely above the medial half of the inguinal ligament, this oblique intermuscular passage measures approximately 4 centimeters in length. It begins internally at the deep inguinal ring and terminates superficially at the superficial inguinal ring. This passage exists strictly to transmit critical anatomical contents. It routes the spermatic cord in males and the round ligament of the uterus in females out of the abdomen. The biological necessity of passing reproductive and vascular structures straight through the musculature creates a permanent structural weak point. Consequently, this precise area is highly susceptible to clinical herniation. The body compensates for this weak point using an active, dynamic defense mechanism against herniation, known as the shutter mechanism. In this schematic, rising intra-abdominal pressure is represented by red force vectors pushing internal contents outward into the inguinal canal. In response, the internal oblique actively contracting, the muscle body thickens and clamps downward against the floor, compressing the passage closed as a protective valve. For you, as medical students, mastering this three-dimensional structural map is the bedrock of safe surgical practice. This anatomy directly dictates the approach for everything from simple abdominal incisions to executing complex hernia repairs. Thank you for watching this breakdown of the anterior abdominal wall, based on the academic teachings of Dr. Vikrant Tripathi at the University College of Homeopathy, Dr. S.R. Rajasthan Ayurveda University, Jodhpur.